This is an introductory lecture about lower limb amputation. I'm a rehabilitation physician based in Australia, and in some other parts of the world, I am known as a physiatrist. Full disclosure, this information is for educational purposes only, and it's not meant to be medical advice. I present this information based on my expertise as a rehabilitation physician in amputee medicine. There are many facets to lower limb amputee management. For example, a surgeon or an allied health may have different perspectives. It's important to remember that if I present some information that is somewhat out of my scope, for example, some surgical information, please remember that I'm not a surgeon. It's also important to consider that practices will vary according to local resources and local knowledge. This presentation is part one of a two-part series to keep the lectures more succinct. Part two will also be available on this channel. Part one covers different lower limb amputation levels, as well as some information pertaining to pre-amputation and immediately after the amputation. Part 2 will cover mostly details post-amputation. This presentation was prepared in 2022, and if you're watching this much into the future, this information may be out of date. With all that said, let's jump into the presentation. So starting with some definitions, a primary amputation is an amputation that is performed without an attempt to save the limb, and that's usually because there's no anatomic option for revascularization, or in those patients with medical risk factors that contraindicate revascularization. For example, they are septic or they have an ascending infection such as necrotizing fasciitis. Secondary amputation is an amputation done following a failed attempt at revascularization. A traumatic amputation is one that occurs in the field at the time of injury. And then there's also the guillotine amputation, which is one done in an emergency. It's usually due to contaminated wounds or infection, or if the patient is exsanguinating. The wound is debrided and washed out every 2 to 5 days until it is free of dead tissue and infection, and at that point, definitive amputation and closure are performed. This is when you may hear a surgical team say, "We've done the guillotine amputation to wait for the limb to declare itself." And this is when they're trying to see where viable tissue meets non-viable tissue to decide where the amputation occurs. Here is an image of a guillotine amputation. This was a multi-trauma patient. In the first image, we can see that he has an open wound with significant soft tissue compromise. The limb was deemed unsalvageable, and the team had to proceed to a guillotine amputation. The limb is then observed for a few days to discern between viable versus non-viable tissue. Initially, as you can see, this was a guillotine transtibial amputation, but he had to proceed to a definitive transfemoral amputation. And why is this? In a transtibial amputation, the gastrocnemius muscle is crucial to flap over to cover this defect, so the stump is functional. Soft tissue is not going to grow over this defect. And since the gastrocnemius muscle in this situation is no longer available, it means that the surgery has to be moved more proximally. And I'll demonstrate this more clearly in further slides. Causes and indications of amputation. So ischemia or necrosis, infection, say infected skin or infected bone, trauma, tumor, congenital reasons. An amputation can be done to save a life or to improve quality of life. For example, a patient may have a very painful wound and may choose to have an amputation to get pain relief, or we may have a patient who has been burdened by regular dressings in the community for years and years. So they may have nurses coming to their home 2 to 3 times a week, but because the time that the nurses come to do their dressings may not be fixed, the patients then have to just wait around all day until their nurse turns up to do their dressings. So a patient may choose to have an amputation for this reason. Peripheral artery disease alone or in combination with diabetes contribute to over half of all amputations. Diabetes contributes to a 10-fold increase for lower limb extremity amputation. Patients with diabetes tend to be more severely disabled. They tend to have an amputation at a younger age. They also progress to higher level amputations, and they tend to die at a younger age too. Now, preoperative preparation. Indications for amputations are mostly effective. Barring the traumatic patients, a lot of our patients have diabetes and vascular dysfunction, and they've had wounds for many years. When they're seen regularly in wound clinic, we're able to observe their progress, and as such, when we see patients heading towards a major amputation, we should be preparing for it. This kind of initiative does vary from service to service, and in the service that I work in, we do what we call prehabilitation, which is rehabilitation before surgery. And I will go into it in more detail in a couple of slides, exactly what we do in our prehabilitation program. Other than a prehabilitation program, we also have early and regular rehabilitation physician input at our acute service. I'm personally at my acute hospital twice a week actively seeking out patients who are pending lower limb amputation, as well as patients who've just had their lower limb amputation. I've never heard of amputee prehabilitation, so this was an actual quote from an orthopedic surgeon in our service. And to be honest, that's really fair enough. Amputee prehabilitation is relatively new. We only started doing amputee prehabilitation in 2018, and since we've been getting good results and also won a state award, the prehabilitation program in our service is gaining popularity. And as much as possible, we still continue to try and provide ongoing education so that more people are aware of our program. Here we have a slide illustrating the traditional pathway post lower limb amputation. After someone has had their lower limb amputation, they usually go from the acute hospital to inpatient rehabilitation to learn to become independent, functioning from a wheelchair. This would include transfers, propelling from the wheelchair, completing activities of daily living while they're still wheelchair-based. Patients in general are unable to start using a prosthesis in inpatient rehabilitation because they need to wait for their wound to heal before they're able to put a prosthesis on. If patients weight bear into a prosthesis too early, there's a chance that their wound will dehisce or just break open. Usually it takes a minimum of 6 weeks post-amputation for the patient to be ready to use a prosthesis. For a lot of our patients, it takes longer because with diabetes and wound healing issues or wound infections, or their overall general health condition may be protracted as well. Now, we're unable to keep patients as an inpatient until they're able to walk with a prosthesis because it would just take far too long. Some patients might be in hospital for months in that situation. Therefore, patients are discharged home, mobilizing in a wheelchair, and once their wound is ready, they attend day rehabilitation or outpatient rehabilitation for prosthetic and gait training. Now, I have to point out that this is the ideal pathway. However, we're often unable to achieve this because most standard homes are not wheelchair friendly. Most standard Australian homes have stairs, some have narrow hallways and narrow doorways, and a lot of them have small bathrooms as well, not large enough to accommodate a wheelchair. So here is a hypothetical conversation between a surgeon and a patient. So the surgeon says, "Your leg is unsalvageable and the only thing we can offer is amputation." And the patient says, "Thank you. Go right ahead." So this never happens. The patient almost always refuses the amputation the first time it is offered. However, as clinicians, we know that the amputation is inevitable. So from the time the patient refuses the amputation to the time the patient actually gets the amputation, this is when prehabilitation can be done. So when a patient has been identified to need a transtibial amputation or higher, they are referred for prehabilitation. Most of what we do in prehabilitation is education. We explain to patients what we do as an inpatient and what we do as an outpatient, and very importantly, to set the expectations that gait training is done as an outpatient. We also teach them about contracture prevention and stump management, some of which I'll cover later on. We provide them information about NDIS or the National Disability Insurance Scheme, which is an insurance scheme that will fund their equipment, their care, as well as their prostheses for the rest of their life. Learning to navigate the NDIS is not a small feat, and it helps if patients are given the opportunity to familiarize themselves with it before the amputation. We also talk to patients about how to transfer and how to avoid falls. Patients get the opportunity to use a wheelchair. Patients are able to talk to a prosthetist and to also hold and manipulate a prosthesis. We have psychology service because clearly an amputation requires significant adjustment. And if the patient consents, we also refer them to peer groups. In Australia, we refer patients to Limbs for Life. Very importantly, a home visit is also undertaken, and this is when an occupational therapist will go and visit the patient's home. So remember in my last slide, I talked about how a patient is discharged home in a wheelchair. This means that the patient needs to have a wheelchair-friendly home, which is when the occupational therapist will suggest relevant modifications and equipment that need to be done to prepare the home. Something else that I also educate patients about, I recommend that patients own their own wheelchair and also make sure that they have wheelchair accessible accommodation, even if we anticipate that they will be a full-time prosthetic user. And this is because there may be times when a patient may not be able to use their prostheses. For example, if the prosthesis breaks and needs to be taken back to the workshop to be repaired, the patient won't have access to prostheses. Or if the patient develops a wound and they need to stop using their prostheses for a little bit in order to rest their limb and allow that wound to heal. These are the two potential situations where the patient will need to use a wheelchair to get around. Now, there are times when home modifications are just not possible, in which case we discuss the risks and help plan what the patient will do given that their home is not wheelchair friendly. We did have one patient who compromised. She was someone who was fit and healthy prior to the amputation, and she was going to have the amputation for chronic osteomyelitis. She was living in a rental property, and it was going to be very expensive to modify it. However, she was not going to live in that property for much longer. It was a single-story house with multiple lifts around, and she needed 9 ramps in order to make the house fully wheelchair-friendly. So after significant brainstorming and counselling, we came to an agreement that she would use the front of the house most of the time, which would be wheelchair-friendly. And in order to toilet, she was agreeable to using a portable commode in the front of the house. Her daughter would empty the commode once a day when she came back from work. This lady also decided that she would take the risk of hopping into the bathroom once a day to take a bath. And out of all the potential scenarios that we came up for the patient, this was the one that was most acceptable to her. We, of course, explained all the risks to her, and she was able to make that decision over a period of a fortnight prior to getting her amputation. For other patients, it may mean the realization that they will have to go to a nursing home after an amputation. For some patients, with this knowledge, they may choose to then not have the amputation and to just live their life to their fullest with their limb in place. And as long as it was clear that the patient had capacity to make this decision, we would respect this decision. We also cover things like transport, and this is because immediately after an amputation, a patient is unable to drive, and therefore we give them the information about what interim options there will be and also the pathway of returning to drive. A program like this takes approximately 3 weeks for us to complete quite comfortably. However, we've been able to rush some of these programs in under 2 weeks. Therefore, if a patient presents to our acute hospital requiring a lower limb amputation, if there is no urgency, if there's a margin of safety to delay the amputation, the surgeons would discharge the patient and refer them for prehabilitation first. So this is what our amputee pathway looks like after the introduction of prehabilitation. Prehabilitation is introduced prior to the amputation. Prehabilitation is introduced prior to the amputation. And what we found is that a large portion of the patients are able to be discharged home with a home-based rehab program, bypassing inpatient rehabilitation altogether. Now, an average length of stay for an amputee in an inpatient rehab unit in Australia is 30 days. Therefore, with this pathway, we save a minimum of 30 hospital days per patient. This results in an overall shorter length of stay in hospital, and since patients have been prepared for the amputation prior, they return to independence promptly and have also expressed satisfaction with the pathway. Bear in mind that the minimum criteria for a patient to be discharged home with a home-based program is that they're able to independently function from a wheelchair, which includes wheelchair transfers, wheelchair propulsion, and accessing essential areas of the house. They also have to be independently toileting. Now, it's important to bear in mind that the prehabilitation program is only ever effective if the patient is engaged. We have had patients before who were referred to the program but declined to attend. What we have also found with the amputee prehabilitation program is that patients are more ready to complete their acute episode and to commence rehab. If the patient has not had prehabilitation, it is not uncommon to observe that the patient is quite anxious to move on to rehab from the acute service, and that's because they have familiarized themselves with the acute team and they're worried about the unknown. If you are one of my colleagues watching this presentation, please always remember that if you are aware of a patient who is pending an amputation, who has not yet had prehabilitation, please get in touch with myself or your local rehab service. Post-op complications include myocardial infarct. It is the most common cause of death in our patients with peripheral vascular disease. There's also pulmonary complications where about 5% experience atelectasis or pneumonia, and there's also new onset renal failure with an incidence of 0.6 to 2.6%. Patients are also at risk of a major depressive disorder. This is more common if the patient is younger at the time of the amputation, if there's significant pain, if they have a neurotic personality or lifestyle, or poor coping skills. Some patients also experience PTSD or post-traumatic stress disorder, approximately 20% after amputations for combat or accidental injury, and less than 5% after ischemic-related or non-traumatic amputations. Antibiotics. Lower limb amputation is often associated with open infected wounds, and therefore lower limb wounds tend to be considered contaminated, and they're high risk for surgical site infection. Therefore, prophylactic antibiotics are advised within 1 hour of the incision of the skin, and administration of antibiotics are associated with significant lower rates of wound infection, 38% versus 17%. Thromboprophylaxis. This is ideally commenced prior to the amputation, as clearly this is major surgery and the patients are relatively immobile in the early days after the operation. And it doesn't matter whether heparin or clexane is used. Post-operative progress. So with very efficient systems in place, this is generally the progress of our patient in our acute amputee ward. Day 0 to day 1, they're generally not as mobile. They're usually still on IV analgesia. They're on supplemental oxygen. They usually have a stump catheter with local anesthetic pumping through it. They have an indwelling catheter, and ideally they should have a rigid removable dressing, and I'll talk about that in my later slides. Day 2 to 4, they generally come off their IV analgesia as well as their oxygen. The indwelling catheter is removed. They start practicing their transfers, they sit out of bed, and they shower with the assistance of the ward nurses. And by day 5 to day 6, they're ready for rehab or for some form of transition care. In terms of what level to amputate, this really depends on the extent of the disease. From a functional point of view, with regards to energy efficiency, the more length of the limb is preserved, the more function will get out of the patient as well as the residual limb. However, more critically, we need to consider if the residual limb will heal, as a limb that does not heal cannot be used in a functional way. There are some parameters to indicate where to amputate. For example, if there is a palpable pulse proximal to the level of amputation, this is associated with nearly 100% rate of wound healing. The absence of a palpable pulse does not necessarily imply that the wound will not heal, but it is associated with a higher revision rate. We can also look at supplemental information, for example, ankle pressures, toe pressures, transcutaneous oxygen measurement, and skin perfusion pressure. However, they tend to be of low sensitivity. In the end, it all requires clinical judgment. Now, here's a picture of a cat and a mouse. I always thought that the rehab physicians were the mouse and the surgeons were the cat, but I have heard before a surgeon saying that they were the mouse. So we're going to start talking about the actual amputation levels first, and I'm going to start distally and move more proximally. Here is just a little bit of revision and an image of a foot. In green, we have the forefoot, which consists of the phalanges and metatarsals. In orange, we have the midfoot, and in purple, we have the hindfoot. When it comes to foot amputations, there are some pertinent biomechanical considerations. Given that the foot is such a small part of the body which has such critical physical function, it essentially carries the weight of our entire body and it balances our body weight over such a small surface area. The more foot length we can preserve, the more function we will get, as this will increase its lever length as well as provide a larger surface area to distribute pressure over. But as I said before, this needs to be balanced against the sustainability of the residual foot. So here are some foot amputations at different levels. Here we have a metatarsal phalangeal amputation, and then we go more proximally to the transmetatarsal amputation. Then we move more proximally to what we call the Lisfranc amputation, where the forefoot is amputated and the midfoot is preserved. And then even more proximally to the Chopin amputation, where the hindfoot is preserved, but anywhere distal from the midfoot is amputated. And then more proximally again, a Symes amputation or an ankle disarticulation, where the entire foot is amputated, preserving the tibia and the fibula. There is also a ray amputation, and this is when the toe, as well as part of the metatarsal, is amputated. And the ray amputations can be done on any of the metatarsals, and an amputation like this may be done, for example, if there is a metatarsal head infection. An amputation like this reduces the width of the foot, however still preserves the length of the foot, which gives us a bit more biomechanical advantage. So here is an image of a transmetatarsal amputation. An incision is made as such. The toe pads are preserved and flapped over to cover the defect, and that is the stump that you are left with. In the realm of rehab, when we think about foot amputations, we are worried about the equinovarus deformity forming. So why does this deformity happen? If we look at the picture here in the middle, this demonstrates our dorsiflexion compartment. In green, we have the tibialis anterior. which attaches to the medial side of the foot. And this is a strong dorsiflexor and inverter. In red, we have extensor digitorum longus, which attaches to the toes, and this helps with dorsiflexion and foot eversion. In purple, we have extensor hallucis longus, which attaches to the big toe, and again, this helps with ankle and toe dorsiflexion. In this picture on the right over here, we have the plantar flexion compartment. We have the Achilles tendon back here, and in here, we have the tibialis posterior, which runs down the medial aspect of the ankle and attaches to the base of the metatarsals as well as the midfoot. The Achilles tendon helps with ankle plantar flexion. The tibialis posterior plantar flexes the ankle as well as inverts it. Now, if a transmetatarsal amputation occurs at this level, you can see that we will lose all the attachments of the toes. And what we end up with is an imbalance in the muscle forces, and you're left with a group of muscles that puts the foot into plantar flexion and inversion. Now, I understand that there are surgical techniques to prevent this deformity, and you'll have to ask the surgeon more about those techniques. But if this deformity forms, as you can see, the pressure distribution will be suboptimal, and you're going to get more pressure in the most distal aspect of the foot. In combination with diabetic neuropathy, the patient is then prone to getting an ulcer here, and there's a high risk of skin breakdown and re-amputation. This is the foot of one of our own patients. So he had the second and third ray amputated. He's got significant diabetic neuropathy. He was a young guy who was very active, and understandably the surgeons tried to save his foot. However, due to increased pressure over his metatarsal heads, as you can see here, he developed a couple of pressure ulcers, and this resulted in a transtibial amputation not long after. Moving on to even more proximal foot amputations. On the left, we have the Lisfranc amputation or transmetatarsal tarsal amputation. On the right side, we have the Chopin or the talotarsal amputation. We lose even more of the foot lever and the surface area. From a rehab point of view, these amputations are not particularly functional in that although the patient has preserved limb length, there is minimal ability for the patient to effectively leverage off these residual limbs. Similarly, the prostheses that we fit for these stumps are unable to provide significant dynamic leverage. In fact, the more energy efficient amputation is the ankle disarticulation or the SIMS. So this amputation is much more energy efficient compared to partial foot amputations. So a fish mouth incision is done as such. The heel pad is preserved and used to flap over to cover the defect. The tibia and the fibula are trimmed slightly distally, and this is the stump that you get. The advantages of the SIMS or the ankle disarticulation. So it actually can be an end-bearing stump. So patients can put weight on this stump for just very short distances. In terms of how this is functional for a patient, they're able to then just wake up at night and walk to the toilet on this stump without having to put on a prosthesis. It's also more energy efficient compared to, say, a transtibial amputation because you have a very long lever with the entire tibia still intact. And the prostheses that we make for this amputation can also give very good leverage. It's also excellent for children as it preserves the growth plates at the distal end of the tibia and the fibula, which means that you end up with equal limb lengths. There are disadvantages, however. The amputation or the prosthesis is not particularly cosmetic. And this is what the prosthesis looks like. So it's very bulbous at the distal end around the ankle because it has to accommodate the distal tibia. There is a window that is cut out in the side of the prosthesis so that the stump can be put into the prosthesis, and the window subsequently closed over. The prosthesis is suspended on the malleoli. The other disadvantage of the SIMS is that the heel pad can also displace, usually posteriorly, over time. So moving on to the next level of amputation, which is a transtibial amputation. And over here we have Heather Mills, who's a very famous model with a transtibial amputation. She was involved in a motor vehicle accident at a very young age. Feel free to take a moment to pause the video to try and guess which side her amputation is. So her amputation is on the left side. As you can see, a transtibial amputation can be extremely cosmetic, and patients can still function at a very high level. So I'm just going to mention here that you hear terms like transtibial amputation or below knee amputation. Although the term below knee amputation is not wrong, it's not as specific because a below knee amputation could indicate a level of amputation anywhere below the knee. If we use the term transtibial amputation, it's more specific as to where the amputation occurred. This is similar to saying a transfemoral amputation versus an above knee amputation. Alright, so the transtibial amputation is the most common level of amputation seen by rehabilitation, It should be done by a surgeon who does it regularly if possible, because there is a lot of skill involved in forming a functional stump. However, this is not always possible, especially if the amputation was done in an emergency setting, for example, trauma, and the goal of amputation is to save the person's life. During a transtibial amputation, the nerves are cut on tension, so the surgeon will pull out the nerves a little bit and cut it so that it will spring back into the muscles, and this is hopefully to prevent formation of neuromas. Neuromas are painful nerve endings because after an amputation, a nerve can still grow and it's looking for something to innervate. And if it grows long enough and it hits the distal end of a stump, it can be very sensitive and it can actually stop patients from walking. The incidence of neuromas can also be reduced if the nerve is buried into muscle or bone. So with regards to the transtibial amputation, the ideal length is when 1/3 of the tibia is preserved. If it's longer than that, the distal portion of the tibia tends to get too skinny, which means we have lesser surface area in the distal end to distribute pressure. If the residual stump is too short, then we get an inadequate lever length and also again reduced surface area to distribute the pressure. The tibia should be beveled at approximately 45 degrees to remove the sharper anterior edge, and the fibula should ideally be approximately 1 to 2 centimeters shorter than the tibia. Otherwise, if it's the same length or longer, it can be quite uncomfortable. There's essentially not enough soft tissue between the bone and the skin. The preferred flap technique of surgeon is then used to close the wound and create a functional stump. This picture over here demonstrates a long posterior flap. And you remember in my earlier slides where I said that the gastrocnemius is used to flap over to cover the defect. And in a new amputee, if you go ahead and touch them on the very distal end of their stump, they will say that it feels like you're touching their calf, and in fact you are. There are other options with regards to the flaps, such as the skew flap, the sagittal flap, or the medial flap. To be honest, I've not seen any of these other flaps. Only recently I've seen a fish mouth flap, and I think that closure was chosen because of the viable soft tissue that was available to the surgeon. Here's a rigid removable dressing. It's also known as the RRD. Ideally, it is applied in recovery or within 4 hours of the amputation. Unfortunately, it is not always achieved because it needs to be applied by our prosthetist. And sometimes the amputations occur after hours when there's no prosthetist available. The rigid removal dressing helps by reducing pain, and it shapes the stump and it protects the stump until the wound is healed. When the rigid removable dressing is applied in theatre, it will control the amount of swelling that happens over the next 48 hours. The lesser the swelling, the less pull it will have on the wound, and therefore that's how it helps pain. And the lesser the amount of swelling that develops, the lesser the amount of swelling we have to get rid of when we are trying to then plan the patient for prosthetic casting. The rigid removal dressing is made of plaster cast, so it is solid like a helmet. And sometimes when new amputees are not used to transferring with a limb, their limb might kind of go all over the place and they might knock their limb against their wheelchair or bedside table, and this helps protect the wound somewhat. There are some patients who also immediately after the amputation experience a phantom limb, and sometimes they might get out of bed with a phantom limb, forgetting that their limb is no longer there, and they go and try and stand on their phantom limb. Now, a rigid removable dressing may not necessarily completely protect a stump then, but it may. So after the amputation, it is important to prevent joint contractures. Now, joint contractures, they can easily develop in the hips and the knees, and that's because the patient is sitting in a wheelchair practically all day. So their hips are bent in a 90-degree position, and if we leave their stump hanging as well, their knee will then be also bent in a 90-degree position. And this is the purpose of a stump board. This is so that the knee can be placed straight as much as possible to prevent a knee flexion contracture. And also when a stump is in that position, it will help minimize swelling as well. To also prevent knee flexion contractures, if you see a patient with a pillow under their knee in bed, please also let them know to take the pillow away so that their knee can be resting in a flat or neutral position. To prevent hip flexion contractures, we ask the patient to lie on their stomach for 20 minutes a day, or they can have physiotherapy to further open up their hips. And I'll show you in a few slides why we don't want hip flexion contractures forming. Moving on to the more proximal amputation of knee disarticulation. This is also known as a through knee amputation. There are a number of advantages of the knee disarticulation amputation over a transfemoral amputation. We have a longer lever compared to a transfemoral amputation. Just like the Symes amputation or the knee disarticulation amputation, it also preserves the growth plates in children. So we have a pair of femurs that grow to similar lengths. These patients are also candidates for end-bearing prostheses because it provides a good surface area to put weight on. And because there's a longer limb, it provides for better proprioception of the prostheses and also distribution of the prosthetic socket over the stump. There are disadvantages as well. Cosmetically, it may not look very good when the prostheses go on, and I'll show you that in the next slide. It's also a more demanding surgical procedure with the risk of increased wound complications. So here is an image of two people with knee disarticulations. This is what the stump looks like, and once the patient puts the prostheses on, you can see how the prostheses looks quite bulbous. The other thing you can appreciate is that the knee center is more distal in the prostheses compared to the native side. Now, when a patient sits down as well, you can see how the knee protrudes beyond the native side. And with a cosmetic cover as well, this can look like the patient has an apparent femoral length discrepancy. For some patients, this is bothersome, especially for patients who are more cosmetically conscious. We did have a young girl who was a transtibial amputee on one side and a knee disarticulation on the other, and she was very bothered by how on the bus it was very obvious that her femoral lengths were different. Moving again more proximally to the transfemoral amputation, so the optimal length of the stump is 8 to 12 centimeters proximal to the superior border of the patella. And this is so that the prosthetic knee components can be accommodated so that the knee centers are symmetrical. With the transfemoral amputation, the distal attachment of the thighs are lost, and I'll talk about this more in the next slide. But to create the stump, the surgeon does a myodesis where they anchor the adductors and sometimes the hamstring to the bone. And they also do a myoplasty where the hamstrings and quadriceps are sutured together over the distal end of the femur to form a stump as such. If a myodesis is not done, we did have this happen to one of our patients who was a traumatic amputee. He did not have a myodesis done, and when he lifted his femur, gravity just pulled his muscles downwards and the weight of the muscles were just hanging by his skin on the tip of his femur. This patient that I'm talking about eventually had revision surgery for his stump. So here we are looking at the thigh abductors and the thigh adductors. So very short transfemoral stumps often end up in abduction, and that's because of the imbalance between the adductor and the abductor muscles. As you can see, as the amputation becomes more and more proximal, you lose more attachment of the adductor muscles, and you end up with a stronger abductor pull. Now, I'll make a comment here that this is, in my experience, theoretical. In my group of patients who are transfemoral amputees, they tend to go into flexion and adduction. And I think this is because of my cohort of patients who tend to be more vascular patients, and they have many other comorbidities, and they may have been in their wheelchair for a long time, many months before they start prosthetic training. So when they finally start prosthetic training, they unfortunately already develop a hip flexion contracture. With a transfemoral amputation, other than having a very short stump to control a long prosthesis, because the knee joint is lost, it's also much more effortful to walk with a transfemoral prosthesis. The walking technique with a transfemoral prosthesis is not particularly intuitive, and perhaps we can talk about that in the next presentation. Pain post-amputation, you can have nociceptive pain, which usually involves the stump, and also phantom pain. With stump pain, you can get acute stump pain. This is expected post-surgery, and it should gradually subside over 1 to 3 weeks post-op. We do get better outcomes with early application of the rigid removal dressing. And if the patient has depression, it may complicate the treatment as well. Patients can also get persistent pain, and in this situation, we need to consider diagnoses such as stump ischemia, whether a neuroma has formed or there's a new infection. So these are images of neuromas. On an MRI, you can see it there where the arrow is pointing, and you can see a neuroma there pulled out. So neuromas can form at the site of transection of virtually any peripheral nerve. The pain is usually well localized to the site of the injury, and usually what I would do is I would percuss around the stump, and if there was a neuroma present, the patient would be jumping out of their chair when I percuss their neuroma. Neuromas can be transiently blocked with anesthetic injection, but in my experience, it hasn't been particularly effective. Otherwise, neuromas can be buried into bone or muscle. Neuromas in general are extremely difficult to treat. As I said before, local anesthetic injections don't seem to work particularly well, so we often have to refer patients to a plastic surgeon And between the patient and a plastic surgeon, they need to discuss whether they want to proceed with surgery or not. A neuroma shouldn't be cut because it technically will just grow back. And as far as I'm aware, it can only be buried. It can't be stitched in because it'll be even more painful. Now, when it's buried, sometimes when the patient moves their limb, there's a risk that the neuroma that was buried can pull out of the muscle or bone as well, in which case the neuroma pain will probably recur. So this is usually a conversation between the patient and the surgeon. Bony spurs can also cause pain, and here's an image of one where the fibula has grown into a sharp point, but these spurs can be really painful and it can be really difficult for the patient to walk in them, in which case they need to be referred for that to be revised. After amputation, patients may get a phantom sensation or a phantom pain. A phantom sensation is any sensory perception of the missing body part with the exclusion of pain. It happens in almost 100% of patients post-amputation, and it can be described as a vague awareness, paresthesia, up to complete sensation of the limb. And it can be quite bothersome. For example, a patient might say, well, it feels like my foot is malpositioned. However, there's nothing I can do to reposition it. In terms of phantom pain, so this is when the phantom limb is actually painful. It occurs in 30 to 85% of patients, with 5 to 10% of patients experiencing severe pain. Phantom sensation and phantom limb typically diminish with time, in my experience usually within a year post-amputation, and this is just the time that the brain takes to relearn that the limb is no longer there. And it also helps when patients walk with prostheses. Poor prognostic indicators is if they had high pre-amputation pain or if they had passive coping strategies, for example, catastrophization prior to surgery. Management of phantom limb pain. So here are a few strategies. So there are pharmacological approaches and non-pharmacological approaches. Most pharmacological approaches are not particularly effective. However, these are the options that are used. This will vary from unit to unit, and it's okay to have whatever approach as long as the unit has a consistent approach, trying one medicine at a time, moving on to the next. So medicines like ketamine can be used short term. On my unit, patients are usually on this immediately post-operatively. Other medicines like amitriptyline, tramadol, gabapentin, oral, sustained release morphine, IV calcitonin, alpha or beta blockers, anticonvulsants, SNRIs, topical capsaicin, and topical lignocaine. Now, there are studies on Botox and they're not promising, and there's no studies on cannabis as far as I'm aware. Non-pharmacological management include things like mental or motor imagery, mirror therapy, virtual therapy, TMS, TENS, local massage, acupuncture, psychotherapy, as well as prosthetic training. So that's almost my last slide. So this is my last slide over here. Now, this here is the Van Ness rotation plasty. It is one amputation that I've always been impressed with, but I have never seen one in person myself. Surgery like this is usually done for patients with sarcoma in the distal femur. As you can see in the top left image, there is a tumor in the distal portion of the femur. That portion of the lower limb is amputated, preserving the distal end. The distal leg is then rotated so that the ankle then behaves like the knee, and that's the prosthesis that is formed for the patient to walk in. Patients with Van Ness rotation plasties can be very, very high functioning. The reason I think I haven't seen one of these in my career is I think it's because sarcoma is a very aggressive disease, and some of these children do not survive into adulthood. Otherwise, if they do, they may become more physically conscious as they get older. And I am aware of one patient who requested that her Van Ness rotation plasty was changed to a transfemoral amputation. Thank you. That's the end of this lecture. And the next lecture will be about post-operative rehabilitation. I'll cover a little bit of gait. I'll cover medium to long-term complications, outcomes, prognoses, as well as a little bit of osseointegration and targeted muscle reinnervation.